Good morning, and under the circumstances, I would like to just say, wow, what a fantastic crowd, and we are looking forward to a very interesting morning. I wanted to quickly go over a few things. So at the end, there will be some time for a little bit of Q&A. I will be running around with a mic, and if you just raise your hand, Rebecca at the back will also probably have a mic. So feel free to raise your hand, and we'll get to as many people as we can. To make this morning possible, we have a few sponsors. The Canadian Foundation for Healthcare Improvement is supported this morning. Bill Callery, I think, is in the audience from CFHI. Accenture as well. Sandra Culver is here. Deloitte, Jason Gary is also in the audience. Hirok, Catherine Galton, I think she made it. Life Labs, Joel Fung, and a few others. And as well, Navarre, John Sinclair. NRC Health was with Ron Carklin. And this morning wouldn't be possible without the support of Rotman. So thank you very much to Rotman. I would like to personally thank Rosemary Hannum. And if you have not met Rosemary, she's up here at the front. She is a person you should get to know, so feel free to introduce yourself to Rosemary at any time. And as well, the more people I meet, the happier I am, and I love to hear your stories, so feel free to introduce yourself to me. But you are not here to hear from me. You are here to hear from Susan and Brian, so without any further delay, Susan Fitzpatrick and Brian Golden.
Great. Well, welcome everyone to the Rotman School. I'm Brian Golden, the Vice Dean of our MBA Programs and also the Executive Director of the Sandra Rotman Center for Health Sector Strategy. I'm especially pleased that we're able to host all of you this week. This is the final week of our Global Executive MBA in Healthcare and Life Sciences. And that program, with our students here today, occurs in Toronto, London, UK, starting this year, in Singapore and the San Francisco area. And the purpose of that program is to break down silos across health systems globally. So I can't think of a better topic than today's focus on integration in healthcare. I've had the good pleasure of working with Susan over the years. We have her most recent former title here, former CEO of OH, but also former Associate Deputy Minister of Health, former CEO of the Toronto Central Inn, and I'm very much looking forward to this conversation with Susan. Susan will start off with some comments, and then we'll have a bit of a chat. So, Susan, welcome.
Good morning, everyone. I'm really pleased to be able to speak to everyone today. When I started at Ontario Health in April of 2019, I think midway through the year, Matt Hart and I had a discussion about whether I'd talk about my experience at Ontario Health. So as I transitioned out of that interim CEO role and welcomed Matt Anderson into the role, we were saying, well, should we still be doing the Breakfast with the Chiefs? But we decided we would continue with that. I will speak a little bit about Ontario Health, but really what I'm going to focus on is my journey with integration and how I have seen the system integrate over a long period of time. So I'm just looking here. This. So Matt and I decided our title would be Integrated Care, the Past, the Present, and the Future. For the first time in many, many years, I am not affiliated with any organizations. I do not have to send my remarks in for vetting. But having said that, I'm very optimistic about the healthcare system. I have had a wonderful front row seat on the changes to the healthcare system. I'd like to share that with you. We'll have plenty of time for discussion. Brian and I will have a Q&A. He asked me if there's any questions that he couldn't ask, but I said, no, go ahead. We'll open it up. So if you'll recall, In 2018, I did speak at the Breakfast with the Chiefs, and I presented on integrated health delivery systems. At that time, my focus was, what is the LHIN's role? And in that presentation, I talked about the future state will change how we allocate funding to match population need, facilitate integrations to achieve delivery networks, submit collaborative QIPs to HQO, report on health outcomes at the sub-region level, manage a single accountability agreement, and provide one simple and coordinated access for care. This is the slide I presented at that time: one needs-based funding allocation, one locally integrated service delivery network with one collaborative QIP, one publicly reported population and health scorecard, one outcome-based accountability agreement. I think at that time when I proposed one accountability agreement, there was a little bit of a sigh in the audience. And then the service provider, one simple and coordinated access system for care. So I'm basically still on that track. And I wanted to just kind of recall, I know people in the room, you have a lot of experience with integrated care, but what is it? So it's networks of organizations that provide or arrange to provide a coordinated continuum of services to a defined population and are willing to be held clinically and fiscally accountable for the outcomes and the health status of the population. I have a little bit about the characteristics, but it's a focus on community, matching capacity, coordinating, has information systems that link, provides information to multiple stakeholders, uses financial incentives and organizational structure, continuously improves, and is able and willing to work with others. And I just recap that so you'll see as I go through my integration journey why that is important. And what are the different types of integration? And I like this presentation in terms of Valentian, I think is how you pronounce the person's name. And he or she took all the writings on integration and came out with a comprehensive approach. So there's integration at systems level, which we're trying to do, but there's also organizational integration, professional integration, clinical integration, functional integration, and then terms that you'll be familiar with: vertical integration, horizontal integration. You don't need to pick up all the information from the diagram, but I think the point to leave you with is that integration is best pursued at multiple levels within a system in order to facilitate continuous, comprehensive, and coordinated delivery. So this was a challenge. I'm doing my own PowerPoint decks now. So tell me whether you like it. So what is integration in the Ontario context? And I wanted to call out to you key milestones over the past 15 years. And when I was looking at that time frame, I thought I could have probably backed up a little bit more. But I really did want to start with family health teams. I think, as many of you know, I spent about 20 years negotiating with the OMA, and we did a lot of work on primary care and family health teams. So I'll speak about that. Moving forward to the Ontario Renal Network, QBPs and bundled payments, health links, sub-regions, the LHIN CCAC integration. I see some home care people here with us today. And then finally, my work at Ontario Health Agency. The family health teams, and part of this presentation really is to give a bit of a construct for the dialogue that will follow. But basically, the family health teams brought together health professionals. They didn't work in teams at the time that was created. I will give a call out for the CHCs, a small model across the province. But with the creation of the family health teams, in a very mainstream way, we started to coordinate services with healthcare professionals across the continuum. There's now 184 family health teams that serve 3 million people. And why is it important? And I'm sure you know this. We can't reach full health system integration if we don't have primary care involved. Next, the Ontario Renal Network. This was a major agreement with CCO, and I think, the significance, again, we brought together people, structures, processes, and programs into one entity, one organization to focus on the special needs of the chronic kidney disease population. And most importantly, we did that within a model that had been tried in Cancer Care Ontario. Can it be replicated? Yes. And so that model has been highly successful for bringing together integrated care around a disease state. Quality-based procedures. Again, starting to integrate care across a continuum by using common practices, best practices. I traveled around to many of the hospitals that were implementing quality-based procedures, and it was fantastic to see the teams of care all focusing and aligning on one set of best practices. Bundled payment. Quickly following quality-based procedures, we came into bundled payment. St. Joe's Hamilton, Kevin Smith pioneered that approach and really started to manage care actually coming into the hospital and then being discharged from the hospital. So it was a seamless continuum of care. And it really challenged how do we bring together funding across silos. And I did work with that. It's not easy because that program, of course, showed that some of the benefits were not in the direct services, but in their impact on the health system. Health links, coordinating access across organizations to link up care. And I think there's a few really important milestones with health links. I was in the LHIN shortly afterwards, but it really brought together providers that had never spoken to each other, didn't know each other. They worked down the street. So the beginning of that relationship approach, the health providers getting together, we have to work together to develop a coordinated care plan with our patients. And I would say Health Links also really kicked off the focus on the patient has to be involved in the patient's care. So that is the past. I'm going to talk a little bit about the present. So sub-regions. And I kind of toyed a little bit, is there something really to say about sub-regions? But I would say my journey in the LHIN was, it started to bring the focus of health links on individual patients to communities. When people working in health links looked at what they needed to do to support those patients, they quickly started looking at the communities those people were living in. So there was, I think, a pretty intense focus on what do the communities look like. And Sarah Downey's in the audience, but I know in the East sub-region, we had all kinds of spreadsheets and placemats, and we, knew everything about the people that lived there. So I think it really did start to get the health system, health service providers focusing on community. The LHIN CCAC integration, I've seen at least one person here from the former CCAC. I think that was an attempt to bring key function activities together to add value. And I guess what I would say on that, if I look back and say what really was important, what's the milestone there? One, it created a focus on home care and integration brought together. I pose a question, and I think it's still an open question. What can happen when home care is more directly linked to primary care and community health service providers? So it really started to expand our notion of who provides home care. The LHIN health service provider integrations, this is work that was being done at the local level. Just leave you with the kind of the metrics. There's 1,800 health service providers, and they have budgets as small as about $100,000. I don't know if Stephanie's here, whether we even had some that were smaller than that, but also have $1 billion. So we were bringing health service providers in. We had such a wide range of organizational skills and talent. And I think if you look at, we had in Toronto 180 service providers and 5 sub-regions, you do the math. to try to integrate a system with that many providers is going to be very difficult. And we know that is a little bit of a challenge for people in the community. So we don't just talk about organizational structure and structural integration. We talk about coordination, structured collaboration, programs being operated together. But it really, again, is the sense that we need to work together. We need to integrate the care around the patient. Ontario Health, merger of 20 agencies. Key support functions and activities are coordinated across operating units to add the greatest value. Just a little bit on the metrics. You know, I think people have said, well, why do this? But there's 20 health agencies. I lived that over my 9 months with Ontario Health, all with their own strategies, their own way of operating. And I think, you know, there's some synergy that can be found when that's brought together. You know, there was 140 sites, almost 12,000 staff, a large operating budgets, $25 billion in transfer payments, 2,000 plus digital assets. And I did want to talk a little bit about digital, but I probably won't get there. 2,000 patient and caregiver advisors. So when we bring that together, I think we can start to kind of redesign what is the perfect system. I do on the side have the home care program because we know, you know, what is the future of home care is you know, still being written, shall we say, and there's been recent announcements. But the home care program, you know, is close to $2 billion annually. With you know, about 900 million in home care operations, 7,000 staff. So it's a big program. And then finally, I just kind of my thinking on the future, I want to leave you with population health, healthy neighborhoods, thriving neighborhoods. You've seen this slide. I firmly believe we can't look at the health of the population by just dealing with health care. We really need to start looking at the creative partnerships across many different sectors. I have an interesting slide we did with work with the City of Toronto in developing an MOU. And we looked at social services, social determinants, the public health infrastructure, air, water, waste, sanitation, transportation. Those are all factors of impacting health. Health promotion and community health services, and then institutional health. So we know if we can bring all that together, we're going to have a healthier population is what we're wanting to do. And I have just kind of called out a few initiatives underway. UHN as an important MOU with the city and United Way to develop some social housing in the Parkdale area. The Inner City Healthcare Associates provides services to the shelter system. And there's lots of work going on that is having the healthcare meet up with other partners to look at the social aspects. So on just to my closing remarks, I think, Brian, I've pretty well kept to my time frame. I didn't specifically put in a slide on Ontario health teams, but I think as you go through that journey and you see the Ontario Health Team initiatives, 24 OHT in the first cohort, is the great excitement that that initiative can do to bring all these pieces together and keep pushing forward. And that's why I'm very hopeful that the system will continue to integrate, will continue to provide better connected services to patients. So with that, I will join Brian.
Great, thank you. Let Susan get settled here and all mic'd up. That was quite a walk down memory lane. It makes me think how old I am. Oh, yeah, memories, or yeah, memories is a nice way of describing it sometimes. It's clear that healthcare time is a different kind of time than others. And I recall, as you were talking about primary care and just making the connection to OHTs. When David Price and I and several others probably in this room were doing the work for Primary Care for You, I think it started around 2015, and then wondering, well, is this ever going to get off the shelf? And clearly it has. We did not get a lot of fan letters from the Ontario Medical Association. And that always surprised us because our view was that physicians should have actually been very pleased by what we were proposing. So we think the only people who really disliked the report were those who hadn't read it. But because we talk very much about physician leadership. Can you share with us, in the context of primary care, how you think physicians will play a leadership role in the emerging OHTs?
I think that, the primary care physician leadership has really evolved over 15 years. When I look at really family practice being largely solo practitioner and what we have today, and many of the primary care leaders, some have emerged from Fitz, but actually are showing provincial leadership in developing these various models, have been instrumental on the OHTs, and are really contributing. And I think if we hadn't put the family health team model in place, we might not have seen that leadership evolve. So I think it's been a great model for that. And I will also say I'm a big fan of the impact of the health links, and I think if you go back over the 15 years and you look at what are the sentinel things that really changed the way we look at healthcare, health links really opened up the ability for primary care leadership to take charge of how care was going to be coordinated, working very closely with home care. So those two really important I would say sectors coming together was really an important milestone from HealthLinks.
So let me pick up on that a bit. I know one of the concerns that was raised a few years back, and possibly is still today, is that with the connection of primary care and acute care, often connected to large hospitals in the region, that primary care will still be drowned out by the acute care sector. And do you have a sense of how that balance, the ideal balance, can be achieved between primary care, home care, public health, and acute care without the big mega organizations dominating, when we know that primary care is essential to a high-performing health system?
Yeah, I mean, I guess I would say if we look at all the keys of success for integration, we have to have professional engagement and buy-in to the changes. I think there's different ways for primary care to be significant within those new structures that are merging. In the East, there is I think a group of primary care physicians from that area that came together themselves to organize how they want to participate. So I feel that primary care is going to start to figure that out, because when they're together, they will be a powerful voice, and they'll really reflect that clinical view of the service. Okay.
Maybe one last question on this before we move on to others. So in your role, I assume as both CEO of OH, but also certainly as Associate Deputy Minister, you had an opportunity to see the variation in health system organization, from Toronto to Kingston to Thunder Bay, and then to much smaller communities. What did you observe? What kind of variation did you observe in the effectiveness of integration across the province? Toronto is a very special place, but it's not typical of the rest of the province. Can you share some of your observations there?
I think, people have said, well, Toronto's probably the hardest place to integrate. I feel it's probably the most exciting place to integrate care. But if you look in, smaller sized communities, we have examples where care is almost completely integrated. So, you could have one family health team. Like I think, some of the areas that have great integration are Peterborough, Guelph, different organizations. And again, where primary care has really come together to show some leadership. So there's definitely variation. I think there's, great initiatives in the north. They were quite far ahead of fully integrating services long-term care, hospital, primary care, home care. So there's models across the province. I guess, part of the question for Toronto is, what is the integration model? And I'm not actually sure what that is at this point, but I think everyone's working very hard to say, how do we, really bring those services together? With patient and family advisory groups, this is what they come back to us all the time, saying, it's impossible to navigate from hospital to hospital, provider to provider, although there's definitely signs of improvement. And that was a little bit on the digital, at least starts sharing the records electronically across the various sectors.
Yeah, so it strikes me, I spent some time up in the Northwest Lynn, and one of the advantages they have is sometimes long-term care is actually in the acute care setting.
Yeah.
Sometimes the primary care leaders are also the hospital leaders. So people wear multiple hats, and that makes integration a heck of a lot easier than when we've got our roles in our bounded organizations.
Well, I would just say, Brian, it is a little bit, when you look at what integration is about, so much of it is the relationships. And I think some of the literature shows, if government tries to mandate or force that can have unforeseen consequences. But when people have strong relationships and they develop trust, they want to build that. That's the most important thing.
Yeah, and I suspect that's why it does take longer than a plan on paper would have us believe for that integration to really emerge and to be robust when there aren't formal systems mandating that integration. Maybe I can shift gears to talk about some really good examples of specialized service integration. You mentioned the renal network, cancer, cardiac. How do you see these kinds of very specialized service programs connecting the patient across the fuller continuum?
I think that those programs are highly successful. We have excellent metrics comparing internationally, so we certainly have to preserve that success. And I think that's some work that the OHTs will start looking at as they look at the services within the OHT geography and boundaries. How do they connect with the more highly specialized services? When I was at the Lynn, we did a little bit of work to look at how do the specialist services fit in with that kind of primary and secondary care. And I think, there's work left to be done on that, but it could be seen as MOUs, relationships, hub and spoke, but I don't believe that every OHT should be trying to replicate an individual cancer program or cardiac program, but they will want to have, perhaps some of that skill within their OHT, but then be able to reach out into the provincial program.
Okay. So maybe I'll pick up on this idea of OHTs learning as new organizations and the replication. So we have nearly 30 OHTs today, and my sense is that many of them are learning individually. They're progressing at different speeds, they will have different resources. And in a truly integrated system, we would expect that the highest performers have the opportunity and the mechanisms to share their successes, and equally, when there are problems for any of the OHTs, as there inevitably will be, we have an opportunity to learn from those so we don't replicate those problems. Do you have a sense, and these are still early days, of how we will facilitate the learning of both the positive and the negatives over the next few years, especially for the OHTs?
Well, I think there's, I'm not an expert on it by any means, but the province has done a lot to try to put in new platforms that will allow that collaboration and sharing of learnings. And I do like the early stages of the OHTs to be learning and to be sharing. At some point you might want to put in a little bit more structure or requirement of the OHT model, but in the early days we really need to look at how is that functioning.
Okay. So that's a bit different than my recollection of the HealthLinks experience, where we said let 1,000 flowers bloom and we'll allow, in fact encourage, variation. From my perspective, we allowed that variation till the very end.
Yes.
What lessons do you think we learned from HealthLinks for OHTs?
I think, I was showing kind of a 15-year kind of journey continuum, and I do feel like Health Links opened up the relationships, the innovation, the ability locally for people to try to figure things out. And they created that, and I think, going into kind of sub-regions and then OHTs, people are kind of continuing a journey. And I think, we get back some feedback. The low rules is good, but a little bit of structure is good too. So how do you get that balance?
And who decides on that balance?
Well, I guess it's probably a combination. People give lots of feedback to the government, and the government takes that feedback and assesses it. I mean, I think the main point is that we have a common interest. We're all trying to deliver health care a little bit better to the patients or clients that we are responsible for. We all want that, and we, perhaps see different ways of achieving that.
So, still on Health Links, massive variation, which was actually quite important because the regions differ significantly as well. What do you think were the greatest contributions of HealthLink? I know there have been formal reviews, and you've had the opportunity to travel the province and work with many of them. What were the greatest contributions, and what did we learn?
Well, I think I have kind of said one of them is the development of the relationships, because I think that really started the journey that is in place today. I mean, I think if you go back and study the OHTs and see, are these collaborators and partners that maybe first got together in the early Health Links days and then continued through. So I would say it really strengthened the relationship part of integration. People got to know each other, they got to trust each other. But I also think it really brought primary care right into the fold in terms of being a success. LHINs had primary care leadership in place. Primary care had a lot of influence with Health Links and with how sub-regions should be developed.
On the this idea of integration related away from acute care and maybe even a bit more away from primary care, we've seen a great need for integration around social services and public health. And we started the week here in our healthcare agenda program with a panel on the coronavirus. And one of the most striking messages there was still how fragmented we are and the division between public health and healthcare, with some arguing that that's an important division and some arguing that makes no sense at all. Can you talk about the role of social services and public health in an effective integrated system 2-3 years from now?
Yeah, I mean, I think they're very, very important. When I was at the Toronto Central LHIN, we worked very closely with public health, and I think it is a key partner in the system. I think perhaps one of the things to think about is, as you get greater integration and collaboration, does it have to be a structural integration? And public health has, I think, provided feedback that that's not the model they want. But as I showed on one of my charts on integrations, they can be very many different ways of integrating. And I think, the next step on a lot of these closer collaborations would be MOUs and partnership agreements. I think that is with the city, the municipality, public health, the health service providers. And I do feel that is pretty strongly in moving forward, and I've talked about the importance of the social services in the future, that the public health piece absolutely has to be a focal area for improvement. And I'm not sure how many of the OHTs have got strong public health partnership, but I think that would be something to really leverage.
There are many people in this room who have been both optimistic of the LHINs when they were introduced and the subregions today and OH, but also critical that in many cases, and this is not unique to Ontario, health systems attempt to integrate services by redrawing the lines on the organizational chart and say we're now integrated, we've got common accountability. But the reality is that it's not only the relationships, but it's other systems. It's information systems to share knowledge. It's reward systems and common fiscal accountability, which you referred to. And I recall when we were doing the work on primary care, during very sensitive times in negotiations between the ministry and the OMA, the idea was we want to get closer collaboration with primary care and the rest of the system, but we couldn't touch funding, and for good reasons at that time. But I've always argued that if you really want integrated care and cooperation, you not only have to change the boxes and the lines on the chart, but you actually have to have common interests created, and that does require a common bundle of funds. Can you talk about how reward systems or funding models need to change in order to get the true integration, as well as the information systems that need to be there to support the structural changes?
Yeah, I mean, I've like throughout the last number of years, people, there's kind of a school of thought that we're not going to get to full integration unless we can change the physician compensation models. I don't think that's necessary. I think you can leave the physician compensation models to be negotiated between the medical association and the province, because I think the real incentives or rewards for physicians to work in an integrated system is everything else. So if the compensation is clear for physicians, and then they understand what is the value proposition from working within an integrated system, which is huge. I mean, it can be basic infrastructure, it can be relationships, it can be referrals, it can be connected to services across a continuum, it can be IT. There's lots of things that would actually be an advantage for a physician to be working in that system. And I was reflecting a little bit on the Kaiser Permanente model, that there you have Kaiser and then you have kind of the Permanente group, which is the physician group that organizes itself and then has a sole agreement with the Kaiser organization. So, I think you can look at how we can create integration without saying we're going to fundamentally change the dynamics between the provincial government and the Ontario Medical Association. When I was at the LHIN, we asked primary care physicians to come to town halls. And they're, going, well, why, should we come to anything that the LHIN is having? And we had lists of all the things that we were offering, whether it was scope or, different access to services. And they were saying, well, why didn't we know anything about this? So that's a little bit about how I would start talking to physicians.
Great. And I would say, to your credit, you invested as CEO of the Toronto Central LHIN quite a bit in developing the capabilities and bringing primary care leaders together. And I know in that room, their opportunity to both develop and share their experiences was really powerful, and it showed a real investment from the LHIN. Maybe one last question before we open it up to questions from the audience. Again, we are in a business school, so I will end with financial incentives. And maybe if you can talk a little bit about whether the financial incentives around bundled care and quality-based procedures are the right incentives. We've had some time, a few years at least, to experiment and to learn. What have we learned about that? What have you learned about that? And are the financial incentives aligned to get both system priorities to the top and as well to satisfy caregivers?
Well, I think the financial incentives in quality-based procedures and the bundled care, I think are putting a focus on the kind of the standardization of the model, the delivery of care, and for the providers that are coming together, allows them to benefit from the rewards, whether they be upstream or downstream. It's not the same system perhaps that we see in ACOs or potentially in OHTs where there could be actually a gains sharing. But when I look at QBPs, and we first started saying, there's a standard pathway for care, and you're going to really, the whole calculation of the funding is going to be on a 5-day inpatient stay, and people were saying, now I'm getting that payment for a service where my hospital maybe is doing it in 10 days or 15 days, people had to change. And you can see very drastic changes in how cataract, hip and knee, a lot of these elective procedures, even stroke care. So that really had people bring the clinical and the financial together and say, how do we optimize the care delivery? So I think they are excellent models. I like to see more bundled care.
I love this idea of gain sharing, and to hear government and OH recognizing that there's incredible brilliance in the system, and when you can turn that brilliance loose to say, how can we make our patients better off, the system better off, and actually me and my group better off together, and we'll share those benefits. That's a wonderful equation. Matt, are you ready?
Absolutely. Okay. So we have a few minutes for some Q&A. I have a mic, and then Rebecca at the back has one as well. And so if you raise your hands, we'll go from this side to that side to this side to that side until we run out of time at 9 o'clock on the nose. And Rebecca's ready to go at the back.
Thank you for the opportunity. Just wanted to ask you about integration of digital integration. We talked about more than 2,000 systems with digital systems within Ontario Health itself, and think about other agencies and how many digital properties and systems we have. How important it is to have integrated healthcare, to have integrated digital system, and what is in the place for us to in the future?
Yeah. I think it's an excellent point, and I did want to put in the presentation a little commentary on that, because on integrated systems, one of the integration features is an integrated IT system and an ability to share. And I think that's a huge frustration in Ontario, that we have invested a lot in IT systems across various sectors, but we're not able to share. So I would hope in the next 5 or 10 years that we can do a much, much better job of connecting, and that's something perhaps OH is going to take a leadership role on. I think the culture has to change, and there's probably maybe IT people in the audience, but we don't need to keep proliferating new systems. We have to figure out how we're connecting the existing systems. There's a little subtext there that I think the government is preparing to deal with, and that's privacy. Because even when we have all the information, we can't easily share it. So to get to true integration, we have to have those connected systems, and we have to be able to share that information, not just with health service providers, but with patients, communities. The information has to be ready to kind of flow.
Hi, I just have a question about, we have been talking about integrated care for eons, and there was one point that was made about how we kind of take the organizational chart and try to integrate everything, understand the importance of IT funding, everything. This time, the impetus that we are hearing is about so that it is easier for patients to navigate the system, family members to navigate the system. What is going to be different this time from what we have done in the last 20 years, so that the integration also happens from the lens of patient and family?
I think it's, when I reflect back, I think we have been evolving. I think, generally people in Ontario healthcare get frustrated with the slow progress, but it's progress nonetheless. And I think we'll see those lessons that we've learned through the last number of years carrying forward into OHTs. So allowing a lot of local collaboration and relationships to find solutions, and absolutely requiring that it has to be with the patients, the families, and the community working to find those solutions. I firmly believe that the design of the system as we go forward has to be co-designed with the families, patients, and communities. So that will be, I think, a piece that will propel this next iteration of integration forward.
Hi, I'm Kathy Kastner, and I'm a patient advisor.
Oh, great.
So I was thrilled to see us up there. On the topic of digital connectivity, I wonder what your thoughts are on the future of getting our healthcare providers to have secure emails. Asking for Will Falk.
Are you asking for Will? Because I was going to say, don't they already have secure email? We have one mail. So again, my experience in Toronto Central Lynn was to provide a lot of hands-on support to get the secure email in place. Like you have busy primary care practices. Like when we met with eHealth and I think it was HSSO at the time, and we looked at what the physicians had to do to get the secure email. It was a lot. It took, I think, 60 or 90 days of work. So people just said, this is too hard. Like if we can go into Apple and just click on something, and get it all organized. And there's been progress. But secure email is available, and I think it's really the support to really support people to get onto that system.
Hi, good morning. I work for a medical device manufacturer, and I'm just wondering, in the spirit of integration, has there been any thought to integrated procurement? So procurement right now focuses on products or procedures. With the formation of the Ontario Health Teams, are they going to start procuring for patient pathways?
Well, the government's announced priority is supply chain management in a very significant scale, and that will be something Ontario Health will take a strong leadership role. So all the reports on supply chain management suggest to me that in the next number of years there'll be a much more focused provincial approach. I use an example from my experience, and that is with home care, that there's like 14 different agreements with medical suppliers for home care, when clearly that could be brought forward into kind of a provincial procurement. So that's just work that needs to be done, but I would say more focus on provincial procurement and really getting kind of the savings. And part of the savings again is to invest in frontline care. We know that we have an aging population, there's significant needs, and we have to have the funding directed into the day-to-day care.
Great, thanks a lot. I really appreciate this conversation, the goal of integration, which I think is dear to the heart of a lot of providers and organizations. And I appreciate the conversations you had, the questions you had earlier about the David and Goliath scenarios and how do you actually bring different partners who are working together in a way that actually allows them to give their best value and not be drowned out in the conversations. So I had the chance of being involved in the earlier health links and regional conversations at TC Lynn. And it was, as you mentioned, it's very much a place where the initial primary care engagement voice first developed, I think, which is really good. Now that we're looking at these entire health teams, which is a much higher degree of investment, involvement in primary care leadership there, it can't be done off the side of the table. So how do we actually support and enable the capacity for a much deeper level of operational involvement of primary care in the achieving the goals of health teams?
I mean, I think that's an important question to be worked out, and there's many different models of how people are compensated, and obviously people that are in salary jobs or even capitation models have some more flexibility as to what they do kind of on their day-to-day. I think the province will probably look at what needs to be done to support the models. I mean, I would say there's lots of capacity within the system for redeployment. I mean, when you run large organizations like I have, you often cannot go forward and say, I need more money. You have to say, I'm going to redeploy staff. I'm going to take my best staff. I'm going to reassign them and, give a lower priority to something. If you honestly believe that Ontario Health Teams are the priority for the province, then look at the shared resources across the partners and start picking off your top people.
Hi, it's Patricia Sullivan-Taylor with Accreditation Canada and Health Standards Organization. First of all, thank you, Susan and Brian, and thank you, Longwoods, for hosting this session. I think it's well-timed. I'm curious, we are in the process, so accreditation in Ontario is actually somewhat different than it is in other jurisdictions across Canada. It's much more system-focused in other jurisdictions, and here it's been much more organization-focused. That we're trying to shift that, and I think OHTs will help do that. I'm curious from your perspective, so we've got a standard, an integrated people-centered care standard that's coming out this year, as well as some other tool sets. What advice do you have for how Accreditation Canada and Health Standards Organization can help move move us along on that journey, so that we're not focused on quality within organizations, but we're focused on quality across OHTs and across the system?
Well, I think it's been recognized by Accreditation Canada for the last number of years. When I was at the LIN, I spoke to Leslie about looking at an accreditation that might accredit a whole health service providers for a sub-region. So that's the way to go. I mean, I think there is value, at an organizational level on the accreditation. We went through it at the LIN for the home care program. So, at the organizational level, you can be kind of assured, as hospitals are, the basic pieces are in place. But I think, with the OHTs, when you're looking at how are all the partners working together, then you're going to be looking at different areas that you want to see the accreditation. And I think, some early thinking has been shown in the OHT applications because it's asking, how are the providers working together? How are patients being involved? All those types of questions.
Hi. Do I have to stand up? Hello.
Oh, hi.
So my name is Ariag. I'm a family physician. I'm also part of the GEMBA HLS. I'm also leading the North Halton, Ontario Health Team, which is a primary care-led OHT. When we came together, I love the idea for the ministry, like a creative destructive kind of idea. We came together and we said, we want to know what the world we live in looks like.
Yeah.
Right? I mean, I know like healthcare for us, it's very archaic. So when we came together, we said, okay, let's design a system that works for not just us, but we will be proud of it for like the next 10 years. People are going to basically inherit it. And we also raised the bar also for patients who are going to be advisors. We said we want influencers because we can't keep kind of doing the same thing over and over again. We came up with amazing things. Then the ministry has been really awesome. Like when they're talking about IT, we have DAPAsoft that came in and is linking interfaces. So things are happening.
Yeah.
My question to the ministry, as in, like, we're not hospital, we have partnerships with the hospital, but we're a new idea. It's an incubational, like a petri dish. What kind of political will is there to support our model as we are going forward? Because I went to Kaiser Permanente. I have an understanding of a primary care physician who sees 40 to 60 patients a day. How does that apply with regards to Kaiser Permanente? We do, like they're talking about messages and emails with OTN, we do text patients back and forth for that. There are compensation models. So the system is really there. The question is, we feel like we can actually help in designing a model. So how much support are we going to be able to get from you guys?
Well, as I say, I'm at large now, but I would say
You're just a citizen.
You're getting lots of support. I think the ministry's identified the OHTs and is, encouraging people to develop their model. It's not a one-size-fits-all. And I had looked at a system in New York where they had put out a number of integrated systems, and there were primary care-led systems. They weren't necessarily the majority. A lot of the leadership does come out of the hospital, but I would certainly like to see the OHTs try different models. I don't think they should all be the same. So I mean, your model sounds fantastic. I'm aware of other ones in the area too. So I think it really, once we start looking at the community, we start tailoring how we deliver care based on the community, then it's all going to make the job of primary care and our health service providers so much easier in a way.
Hey, Susan. Sean Kerr, Trillium Health Partners. I finally get to ask you a question in public. First, I want to say thank you. I've had a chance to work with you for over 10 years on a number of different things that you talked about today, and I've seen who you are as a leader and as a person, and you've dedicated your career to public service, and I think that is very, very important. And I know a lot of people have had a chance to get to work with you, and I've seen you be driven by how do we drive results that are positive for people with a healthy irritation within action. And so I want to say thank you, because I think that's really important, and I think it's great that we've been able to benefit as a province from your leadership over many years. There you go. Round of applause.
Thank you, Sean.
And now the really tough question.
Yeah.
So you talked a lot about different enablers to integration. Different tools have been put in place to whether that's facilitate QBPs or bundled care, or through structure or funding or IT. There's lots of different tools that can facilitate integration. So you have a magic wand. You get to choose one tool that you would put in place. You are at large, as you told us earlier. So there's zero political repercussions from what tool you put in place. What is that tool and why?
Well, I mean, I think I've indicated that, but I would probably say there would be two things.
Good.
I know, but I'm changing it. I think the population health piece absolutely needs to continue to be developed. And I know people are a bit cautious because they go, like, we don't really even have health care figured out. And now you're, wanting to extend it into something that's much more complicated. And I did reread a report on integration of health and social services that came out of the UK. And when I was rereading it, I was struck by how critical it was. They said it really isn't working, but it really demonstrated to me how complicated that's going to be, but are we ready to start to take that on and have really meaningful relationships with cities and municipalities and public health? I would say I think Hamilton is probably one of the furthest advanced in those relationships. Ottawa, we did some great work in Toronto, and there's going to be many more. So that is work I would like to really see continue in a major way. But the other piece, if I did have a magic wand, is I would really like to see something significant be done on the digital. I just think that is, the next piece. When I was looking over everything we've done, and I wanted to say, well, what have I actually done that would advance the digital agenda? We did work on getting the EMRs in for physicians. We tried to kind of coordinate the EMR system for the CHCs, but yet I think it's been very minor progress. In the TC Lynn, we did actually ask our health service providers in the accountability agreements to say, get the e-notification, get your hospital HRM reports, get all of that hooked up, because 5 years ago even that was not all connecting. But the magic wand would be, even if there's thousands of systems in the background, that they all actually have to contribute to something that can be integrated and provided to patients and providers.
I love your not willing to accept the premise that there is one thing, and I think every system that has failed, every solution that has failed has been focused on one system, whether it's IT or structure or funding. It's all of that integrated together, and you have to see it as a package.
Last question.
Hi, Christina German, Chi High Digital Innovation, and also one of Brian's students. Just kind of carrying on the theme of digital innovation and digital enablement, what are the major, opportunities that you could sort of see for the future for digital enablement in any of our systems, in any of our hospitals, in any of our organizations? Like, what would you say would be some real opportunities that we could pursue?
Well, I would actually say it's not any of our hospitals isn't the question, because the hospitals have digital. What would be really great in the OHTs is to make sure that all the providers do. So, there was a real struggle with some of the small providers to put in the community mental health, the community social services, to put all that data, and some of them saying, we don't have even have computers or laptops, let alone IT people that can, bring all this data. So, a measurement of success would be to say that every health service provider within an OHT is fully connected to a digital record and can access that. Because we're nowhere near that.
With that, thank you, Susan. Thank you, Brian. So as you're packing up, our next Breakfast of the Chiefs, the invitation will be coming out soon. It's going to feature Jennifer Zellner from the Canadian Foundation for Healthcare Improvement. So keep your eye out for that. Thank you very much and have a good morning.